regarding acute cholecystitis in pregnancy and its outcomes if you do surgery and if you do not do surgery. Praveen, you can
Yes, sir.
start.
Yes, sir. Good evening to everyone. Today's topic will be today paper discussion will be on operative versus non-operative management of acute cholecystitis during different trimesters of pregnancy, authored by Miriam Main in the Department of Surgery, University of Washington. It was accepted in the August 27, 2023 and published online on November 15, 2023 in JAMA Surgery. The JAMA surgery has an impact factor of 157.375 and a SGR factor of 6.695. Coming to the topic, the most frequent non-obstetric induction for surgery during the pregnancy is infection, which includes acute cholecystitis. And the Society of American Gastrointestinal and Endoscopic Surgeons have given guidelines recommending that cholecystectomy as the treatment of choice for pregnant patients presenting symptomatic gallbladder disease, regardless of the trimester. But this recommendation is based only on limited evidence and it's only about maternal and pregnancy risk when cholecystectomy is not performed, and it focuses only at the risk of cholecystectomy. This pregnancy risk can be of wide range such as miscarriage, intrauterine fetal demise, stillbirth, preterm delivery. Despite of this recommendation for cholecystectomy during pregnancy, many surgeons still opt to delay the surgery until after delivery. The aims and objectives of this paper were describe how often pregnant patients with acute cholecystitis receive cholecystectomy and to assess the risk of adverse pregnancy outcomes in patients with acute cholecystitis compared with a matched cohort of pregnant patients without acute cholecystitis, and also to compare the rates of adverse pregnancy outcomes in patients presenting with acute cholecystitis who did or did not receive cholecystectomy. This is a retrospective cohort study of pregnant patients with an index diagnosis of acute cholecystitis during pregnancy using the IBA market scan commercial claims and encounters data from January 2007 to December 31st of 2019. And the diagnosis and procedures are represented using the classifications such as International Classification of Diseases 9th revision, International Statistical Classifications of Diseases and Related Health Problems 10th revision, and current procedural terminology. All pregnancies in the market scan database were identified using a slightly modified version of previously validated algorithm. This uses ICD-9 codes and CPT procedure codes, which are mapped related to pregnancy length and outcomes, to which author had added ICD-10 codes. So they have identified approximately 9.7 million unique pregnancy episodes with estimated start date and end date pregnancy outcomes for each episode. The inclusion criteria includes, after identifying the pregnancy episodes among the enrollees from the age of 15 to 55 years, episodes in which acute cholecystitis was diagnosed during the pregnancy were identified using the acute cholecystitis case definition. And also they included the index date of acute cholecystitis as defined as first date on which an acute cholecystitis code had occurred, and this code was considered as the index diagnosis code. For any enrollee with more than one pregnancy episode with acute cholecystitis, they included only the first pregnancy episode. The exclusion criteria includes pregnancy with multiple gestations, ectopic and molar pregnancies, and those ending in elective termination of pregnancy. And patients with cholecystectomy, gallbladder cancer, cholangiocarcinoma, or acute pancreatitis prior to the index acute cholecystitis diagnosis date were excluded. And if claims occurred prior to start of pregnancy, and this criteria applied to both acute cholecystitis and control participants, were excluded. Treatment type, they have categorized based on if the treatment of acute cholecystitis is considered to be done if patient had a CPT procedure code for them during the pregnancy, and if patient did not have cholecystectomy during pregnancy or on the pregnancy group, they are considered in non-operative management group. These data were analyzed from October 2021 to July 2022, and all statistical analyses were performed using R version 4.0.3. And to assess association between the acute cholecystitis and adverse pregnancy outcomes, the outcomes were compared in the cohort group with acute cholecystitis group with a propensity score, matched cohort without AC. Can anyone tell what is propensity score?
No, you carry on first, then we can ask about that.
Yes, sir. No, sir, to explain now, sir, about propensity score.
Yeah, I think you will explain it.
Okay, sir.
What you do, you finish the first part. When we stop for critiquing, then we can go for the propensity score.
Okay, sir. And the duplicate records subsequent pregnancies in the same individual, and all the individuals failing to meet inclusion criteria were eliminated out from the study. A logistic regression model was made using the data combined with cohort with acute cholecystitis and with non-acute cholecystitis as outcome. And they used several variables such as maternal age, gestational age, hypertension, diabetes, alcohol use during pregnancy, drug use, obesity, pre-cesarean delivery, history of preterm delivery, history of multiple births, vaginitis, urinary tract infections, and obstetric comorbidity index score. This model's fitted values in the logic scale were used as propensity scores to match each patient with acute cholecystitis with 4 similar controls. These control participants were eligible to match with a given participant with acute cholecystitis if the pregnancy was ongoing at the gestational age at which acute cholecystitis has been diagnosed for that patient, if only if the absolute difference in propensity scores was less than 20%. And for each randomly chosen patient participant with acute cholecystitis, 4 eligible control participants were matched. And if fewer than 4 eligible controls were available, then no control participants were matched to the patient with acute cholecystitis. If more than 4 control participants had the same difference, then those 4 were chosen randomly. The proportions of pregnancy loss and preterm delivery were calculated for the participants with acute cholecystitis, stratified by the trimester, and matching controls with accompanying 95% of confidence intervals, which were calculated by odds ratio between the two groups.
Yes, Anas.
Yes, sir.
Yes, your critique.
What you understand?
Sir, as in how significant the journal article is, right, and how helpful the article will be is so
Yes,
basically
yes, critique it. So
yes,
critique it as per.
in terms of prose, sir, it's a recent article, sir.
Good,
So that is one, and it is published in a journal which has a high impact factor.
good.
And in addition, as mentioned in the journal, that the topic, uh, like usually they have compared the adverse pregnancy outcomes with relation to acute cholecystitis, but not in terms of the treatment, like not in terms of how cholecystectomy is affecting that. So that is also adding to the pros. And so the criterias are also well defined in terms of inclusion criteria and exclusion criteria.
Okay, anything
In
else?
and So like it's a retrospective study, so that will be like that is not that would be considered as an against factor, sir. Is what my like I'm not sure whether that will be a for an or an against factor, sir. And like here, nothing about randomization was mentioned, sir.
No,
So
you can't randomize when you are doing the retrospective.
retrospective, yeah. So like retrospective studies, so randomization was not possible. So like that could be an against factor, so in this study.
So randomize, even when you talk about retrospective study, there is no question of randomization.
And yes,
So retrospective study itself is can be a negative in certain this thing.
yes, sir.
But
Yes, sir.
anything else?
Uh, so these were the points I could think of, sir.
Nikita?
Yes, sir. In addition to the points which she had told, the study data from which it was taken, it was 2007 to 2019, which is a huge time period, which gives a huge data into the study, sir. That is a pro. But whereas taking the data from an insurance board is a against point, because it would not include all the like all the strata of the community or the population. So that would be an against, sir. it would
How
be
how
sir, only the insurance people, the people who are socially stable enough to take an insurance are included in the study. They
no,
are
correct, but
having
how does
No.
it alter the question, what question they're asking to study this? How does it alter?
because the healthcare facilities which are available to them will differ. If the patient has cholecystitis, the medical management how they have been treated will vary from a uh, socially less.
No, no, no. See, they have not said this is a population study. They have said this is a cohort of patients who have insurance. So if they had extrapolated the results and said this is applicable to the entire population, then your argument holds. They have
Yes,
not.
sir.
They have said, we have got data from the people who have, from the insurance data. Agreed that it will
Because
not.
otherwise it would have been very difficult to manage that data for such a long time with such accuracy if it
Yes,
was
sir.
not for insurance data.
Yes, sir.
Agreed, but if at all they said this data we have got from insurance and we can extrapolate to the entire population, then you may be correct. The treatment that the people who are less fortunate and who do not have insurance may not receive optimal treatment. So it is difficult to then, say that this is representative of the entire population. But what they have said is correct in the sense they have done it from the database that can be reliable and because insurance database will be obviously reliable because whoever has taken insurance and whoever has claimed it will be represented in the database.
Yes, sir.
Anything else?
Uh, I think that's it from the methodology, sir, as of now.
Ravi,
Vinod?
Sir, regarding the propensity score, sir, what I read is propensity score is
no, don't talk about propensity score.
no, sir.
No,
Just I want
no.
to
We'll talk about statistics later. Critique.
no, yes, sir. That's what I'm meaning. They mention it as
Okay.
1:4. How come it favors or against? I mean, if it is 1:4, which means a patient with acute cholecystitis is one patient and without patient 4, I feel that it may the values the percentages wise it comes more towards if a patient if 250 patients included with acute cholecystitis and 4 patients, I mean 1,000 patients in. Hello, sir.
You have not understood. What they have done is they have taken one patient with acute cholecystitis and they have compared 4 people who did not have acute cholecystitis.
Yes, sir. Yes, sir.
So just to make sure that it is, we will come to that later, but it is not that they have taken 4 with and 4 without, but 4 patients who are pregnant but did not have acute cholecystitis,
Yes, sir.
who had all the pregnancy related complications, the adverse event. So that is what they have done, and that is to ensure, again when we talk about propensity matching, we will talk about that.
Okay.
Sania, Abdul, anything else?
Nothing, sir. I think they've covered both for and against whatever I had thought for this article.
Okay. Sir, anything to add, sir?
I think that's all. Retrospective, but such kind of analysis, has to be done retrospectively.
It is very difficult to do it prospectively because you won't get that large numbers.
Only negative you can think of is because it scales a large period of time, the recommendations, over that period of
Guidelines
time
might have changed.
might change, and the treatment modality, because many of these operations or non-operative treatment is dictated by the insurance companies based on the current guidelines. It might have changed. So that because of
Yes.
large period, there may not be uniformity.
Yes, because earlier they used to tell first trimester, usually they were not recommending cholecystectomy, they were recommending try to avoid it with the fear of birth defects to the baby because of the effect of anesthesia. But now the current recommendation is you in all trimesters you can do after explaining the risks of adverse events.
Correct.
Sir, but still they
This
say
thing.
first trimester better to avoid till organogenesis happens.
No, there is
No,
a.
that current recommendation. Sir,
I don't think there is any current recommendation which says you don't do it in first trimester. Organogenesis.
current recommendation for appendix as well as gallbladder says across all trimesters you can operate after explaining the risks of adverse events to the patient, and it is equally safe.
Okay.
That is what the current recommendation is. All like all top societies, current recommendation for lap appendicectomy and laparoscopic cholecystectomy, they recommend irrespective of the trimester of pregnancy. That surgery has equal this thing.
Okay.
No, actually surgery is better. The adverse events are
That's what.
more if patients have infection. Adverse events are more. So
More correct.
because surgery is better, the recommendations are for surgery.
Hello, sir. Sir,
Ah.
can we do a follow-up for a retrospective study, sir?
You can do follow-up in the sense retrospective study. You can take the database of the patients, call the patients, and find out how they're doing.
Okay.
But it depends on for what you are doing. For in this case, there is cholecystectomy already done, and if at all, if it had to happen, the adverse events would have been documented in the insurance.
Okay, sir. So in this, they have mentioned like 1 year follow-up, sir. So that means, so
That is
according
what
to the
1 year
insurance,
follow-up.
even that.
Yeah,
Follow properly for I think organogen. I think the other adverse events. I think.
Okay, sir.
Okay, Praveen.
Yes, sir. Sir, can surgeon's preference and patient's preference can be considered against, sir,
No, it can't
in
be.
this?
Why should you consider that?
what do you mean by that?
Sir, means they didn't. There is difference in surgeon's opinion regarding surgery and patient's preference. Even if surgeons prefer for surgery, patients might um,
No, here
decide.
what they have
So,
here what they have said is in USA. I think I don't know if Ravi Shankar sir also agrees. I think they go with the guidelines, and insurance only pays if you are following the guidelines. You can't have the surgeon's preference. Like you can't say when there is no surgery needed, you say surgery is needed, and insurance will clear it. So probably the surgeon's preference wouldn't have come into picture here because they would have followed the clear-cut guidelines. Patients' preference, they themselves have said that patients may not opt for to undergo surgery. So those patients
yes,
also they have followed it up.
yes, sir. Okay, sir.
Sir?
Yeah. See, the thing is, they are looking at adverse events. So patient choice, surgeon choice will not have any effect.
Okay, sir.
See, the thing, most important thing you have to know is this. I think JAMA surgery has the highest, this
Impact factor.
all
Yes, sir.
surgical journals, amongst all surgical journals.
Yes, sir.
I think
Praveen, your turn.
it's even
Yes, sir.
more than NEJM. I think it's even more than NEJM. NEJM is the
NEGM, yes.
1.8 or something. Yeah.
Praveen, you explain about that propensity score which you're talking about.
Yeah.
Yes, sir.
Now you talk about it.
Sir, it can be defined as probability of each individual study subject being assigned to a group of interest for comparison purposes. This ensures that there is even distribution of confounders between the groups and increases the bit so that the group can be compared. It is also the index which describes how the observed confounders are collectively distributed in the each study subject so that the study subjects can be comparable or exchangeable.
Yeah.
And this is calculated based on multivariable or multiple logistic regression. in which the confounders to be adjusted are included as independent variables, that is X variable, and to which group assigned, that is cohort group, is considered in dependent variable, that is Y variable. This logistic regression is a classification algorithm. It is used to predict a binary outcome based on a set of independent variables. It is of usually 3 types. In binary outcome, it shows that there are only 2 possible scenarios. Either the event may happen or it does not happen, such as success or failure, true or false, yes or no. In multinomial logistic regression, it is used when one categorical dependent variable with 2 or more unordered levels. And for example, if you want to predict the most used transportation type in 2030, then the output will be as there will be very different multi outputs such as train, bus, tram, bike, etc. It is multinomial logistic regression. In ordinal logistic regression, the dependent variable is ordered. It will be in an order, such as t-shirt size, which is S, M, XL, agree, disagree. So these are the logistic regressions. By calculating the propensity score, it will be used for matching between each subject and the cohort group, so that there will be almost which will be comparable between the 2 groups.
What they said, propensity scoring with reverse probability. What is that? That is what they have said, no? That propensity scoring with reverse probability.
Reverse
No, sir, I did
weighted
not mention, sir.
probability.
What is that?
Reverse
Reverse-
weighted like balancing, sir. So
Correct.
in order to balance the results, once the sampling in like inversely proportional to the sample will be changing the outcome, sir, in order to balance the results finally.
See, basically, the inverse probability is to ensure that result doesn't matter. It is just the groups that are comparable. You understand? If you just do propensity scoring, the results may change. But if you do inverse probability also, that is much more selective and ensures that the 2 groups that you are planning to compare are as closely matched as possible. Nikita, did you understand?
Yes, sir. Yes, sir.
Yes, sir.
So, where is propensity scoring applied, Praveen?
Sir, it is commonly used in retrospective studies, sir, so that to if random, usually in prospective study, randomization is a good thing. So to overcome that lack of randomization, propensity score is used in the retrospective studies, sir. So that each groups will be comparable, sir.
Aina,
Yes, sir.
did you understand?
Yes, sir. Like that is what even I had read, that in studies where randomization is not possible, in order to overcome like the confounding factors is when you apply propensity score, sir.
So, to give you example, let us say they are comparing pregnant women who have, who have had acute cholecystitis and who have had surgery and who have not had surgery. In both groups, what they are doing, making sure is if that particular patient is diabetic, drug addict, and previous miscarriages, whatever. So all what the disease they mentioned some other index. No? What is that called? I forgot that. So you make sure whatever the probable confounding factors are there in that particular patient, you find a more different individuals who have similar age group and all the demographics and the comorbidities, smoking, and all the possible confounding factors. And so 1 in 4, if you match them, then you will find one person who is closest to this person, and then you take that person. So that way you are comparing like for like. So you don't worry about the outcomes of these patients. That is called inverse probability. So you don't worry about whether they had miscarriage or not. All those things do not matter. It is only the patients being compared with each other as closely as possible. That is the this one, a propensity scoring with inverse probability matching.
Yes, sir.
Niranjan?
Yes, sir.
Yes, sir, I agree.
Okay, Praveen.
Yes, sir.
Continue, man.
Yes, sir.
If
So,
anybody
and,
else wants to come in on this, because I think this is the most important part of the study. Tanya, Abdul,
No, yes, sir. I had doubts, but now they are cleared. I understood what propensity score is coupling.
Nikita, did you follow this one reverse probability situation?
Yes, sir. Yes, sir. I read a few examples also about it, sir.
So
Yes, sir.
basically, it doesn't matter whether the person has had miscarriage or whatever. The end result doesn't matter. What matters is how closely they are matched to each other. So that way, you are eliminating the possibility of bias even more. Let us say if you just match propensity scoring and that person had, you have somehow managed to take only patients who have had miscarriages, then obviously your results will be skewed in one direction compared to the other. You follow? So then you say that if you do surgery, the patient will not have miscarriage. If you don't do surgery, the patient will have miscarriage. So then you are coming to wrong conclusion. You follow?
Yes, sir.
yes, sir.
So that is what you have to do is you do propensity score matching with inverse probability. Then you don't worry about miscarriages. You're only worried about how well the two groups compare in terms of their demographics, in terms of their comorbidities and age and everything else. What happens in terms of the adverse event, hopefully will be equally distributed, and then you can say surgery actually benefited this patient compared to patients who are managed conservatively. So then your conclusions will be more scientific and logical. If you didn't do that, then there is a chance that there may be a bias of only including people who had adverse events in the other group.
Yes, sir.
Yes, Praveen, continue.
Yes, sir. And can anyone tell what's odds ratio?
Nikita,
You ask someone particular.
Sir.
You ask someone
Odds.
particular, odds ratio.
Sir,
Nikita.
Nikita?
Yes, sir. Odds ratio is basically the strength of association between exposure and outcomes, sir.
correct. Good.
Praveen.
Yes, sir. Yes, sir. It is association between the exposure and outcome. If odds ratio is equal to 1, then it says that exposure doesn't affect the odds of outcome. If it is greater than 1, then exposure is associated with higher odds of outcome and vice versa.
So the higher the number, the higher the chance that a particular event is associated
Outcome will occur.
with outcome. Yeah.
Yes, sir. Yes, sir.
So to give an example, if diabetes, smoking, lung cancer, odds ratio, if you're comparing, odds ratio will be something like 3.7 or whatever, then you know that definitely smoking causes lung cancer.
Yes, sir. Can I continue, sir?
Yeah.
Yes, sir. Coming to the results, between 2007 and 2019, a total of 5,932 pregnant patients with acute cholecystitis case definition were found out. Among these 5,759 patients could be matched using propensity scores with 1:4 ratio with 23,036 controls without acute cholecystitis. And out of this 5,932 patients, only 3,426 met the insurance enrollment criteria. And among this, trimester 1 pregnant patients were around 1,639, trimester 2 1,000, and trimester 3 of 786 patients. And out of them, overall 1,182 patients had received cholecystectomy. In trimester 1, there were 684 patients, trimester 2 401, and trimester 3 94 patients.
Praveen, trimester alla trimester.
Trimesters, yes, sir.
Yeah.
And these are the demographic data between the two groups, surgical and non-surgical patients. And coming to clinical outcomes for the matched cohorts.
One slide, go back one slide.
Sir.
Yeah, are the groups equally matched in terms of the trimester?
Yes, sir. They are matched based on trimester, sir. 1, 2, 3.
Yeah. Okay.
Yes, sir. Based on the propensity score matched analysis, pregnant patients presenting with acute cholecystitis across all trimester had higher rates of adverse pregnancy outcomes when compared to patients who did not have acute cholecystitis. And pregnant patients with acute cholecystitis had higher rates of adverse pregnant outcomes in each trimester than patients without acute cholecystitis. And this is the comparison between the two groups, suggesting that in all the trimester 1 and 2, 3, based on the odds ratio, there is higher risk if pregnant patient had acquired acute cholecystitis. This is the same data. Coming to the clinical outcomes associated with the treatments, when surgical treatment of acute cholecystitis across all trimester, it is associated with a lower rate of adverse pregnancy outcomes compared with no surgery. That is here odds 0.75. And based on the trimester, the surgical treatment was associated with significantly lower rates of adverse pregnancy outcomes in first and trimester when compared with no surgery. And this is a table suggesting between the two groups of surgical and non-surgical patients. Based on the adverse pregnancy outcomes, they taken the adverse pregnancy outcomes of pregnancy loss and preterm delivery. And here you can see the forest plot. Here, the preterm after surgery, they suggest that it doesn't. It is safe for the preterm it favors surgery in terms of preterm delivery, and it doesn't favors for the pregnancy loss, as the odds ratio is 1.08. That is, there is high risk in the first trimester, but in second trimester and third trimester, both preterm delivery and pregnancy loss is very less. That is 0.73, suggesting that there is not associated. So it favors surgery in both second and third trimester.
So,
Yes,
Praveen,
Sainas?
Praveen, you
Yes,
went,
sir.
go back to slide. Not this, go back one more slide. The slide which shows that, irrespective of the surgery or no surgery, acute cholecystitis was a risk factor. Go back.
This
Go
one,
back.
sir.
Yeah.
This
one.
table, sir.
Yeah. What does this indicate to you?
Sir, in pregnant patients, if there is acute cholecystitis, it is always risk, sir.
For both for pregnancy loss and
Preterm delivery.
preterm delivery.
Yes.
So, is this so when the associations made a recommendation that cholecystectomy has to be offered, now there is data to support that.
Yes, sir.
Okay, so this is
Yes, sir.
one of the most important slides. So previously,
sir.
if you remember, in the first comments you made that though surgery was being recommended, there was no data to prove that. This is the data.
Yes, sir. Yes, sir. Now we
large
have the data.
cohort of patients. And they have good data, though it may be retrospective, but it shows that irrespective of whether surgery is done or not, acute cholecystitis is a
Risk
factor in terms of negative impact for
outcomes of pregnancies.
pregnancy, adverse outcomes. Okay.
Yes, sir. Yes, sir.
Carry on.
Yes, Nikita or Renas.
Yes, sir. I would like to point out, start the critique with a point that out of 5,700 patients, only 3,400 were considered as insurance criteria, sir. So in two different tables for propensity scoring, they used as 5,000 patients with AC to make the propensity scores. But when it comes to analysis, they took only 3,400, sir. Patients with pregnant with acute cholecystitis.
Praveen?
Praveen has
Sir.
explained why they were why they took
Yes,
so.
sir. Sir,
Ah,
because there was insurance criteria, sir. If only if it is 100% claimed, then they took it as this one, sir. It's a true surgical case, sir. So that's why out of 5,932 patients with acute cholecystitis, only 3,426 met the criteria, and they took all those patients, sir.
You have any problem with that, Nikita?
Because they want to ensure that all cases are true cases. So that's why they took.
Do you have any problems with that?
Yes, sir. Yes, sir. I do have a problem with that, sir.
Why?
So should I consider this n value to be 5,900 or 3,400 is my question, sir. Because in two different instances, they considered n value like pregnancy with AC to be either 5,900 or 3,400, sir. That's why. That is the reason. So my study group A should be either 3,400 or 5,900, but not both. So
N value they took us 3,426 for all the results, sir.
but to make the propensity score, they used 5,900 in the first
No, propensity
Propensity
propensity score is only for diagnosis of acute cholecystitis, right? Not for the
Yes, sir.
treatment,
Yes,
intervention,
sir.
and all that. So
Sir,
for
but
that, they have
they have distributed the comorbidities basing on the propensity score, sir. If, of these 5,000, only 3,000 were selected. We don't know how many patients with comorbidities like diabetes, hypertension, diabetes were included, or more into that 3,000 or less in the 3,000.
no, that cannot be this thing, because they have selected only those 3,426 patients for results of the outcomes and all that, like lab chole, how many, whether they have done or not done and all. But out of those, what I think they're trying to do is they're trying to match with the acute cholecystitis and without acute cholecystitis in those pregnancy, and then they have matched it for that. So that's why they've taken the true number. But as Praveen said, because they had to complete to avoid the bias of this thing, they've excluded those patients whom they have not considered as complete intervention. That is what is right, Praveen. That is
Yes,
what you
sir.
said.
Yes, sir. Yes, sir.
Yeah. So to analyze the data, they've used only 3,426 patients, but to match the propensity score for acute cholecystitis versus no cholecystitis in pregnancy, for that to match the propensity score, they have used all the data. There, it doesn't matter, no, whether they have undergone intervention or no intervention.
Okay, sir. Yes, sir. Yes.
Got
it.
Sir?
I think again, Nikita, this is what you have to understand about the reverse probability. So the results of the system doesn't matter. I think only patients who have had the complete data, and again, insurance people don't care. They are not bothered about whether you are offering surgery or not surgery. So the people who have actually analyzed the data have no bias. And people who have entered the data from insurance company also, they don't care. So I think basically these people have taken all the data that is available, matched them, and then only taken those patients who have completed the treatment so that you will get a proper outcome. So that is
Okay,
why
sir.
they have eliminated the remaining patients. That's all. But your
Yes, sir.
doubt is valid. Your doubt is very valid.
Okay, Praveen. Any other critics? Sania, Abdul,
And
Vinod.
sir, when they were like in the methodology, they pointed out about all the comorbidities. I thought in the analysis they would have made some association with the uh, comorbidities and all, but they concised it to one index saying Charlson morbidity index, and they did not make any specific association except one point they have mentioned, sir. Half of the patients had comorbidity index greater than 1. So that was the point. And about the follow-up, sir, in the methodology they told 1 year follow-up, as I have mentioned previously, but in the results and analysis there is nothing about the follow-up, nothing about the preterm deliveries, what happened to the any outcomes of that. Yes.
Correct. Nikita, your points are very valid, but you have failed to understand the nuances of a prospective and a retrospective study. See, in prospective study, you do a protocol and you follow the protocol. In retrospective study, there is no protocol. So if you try to do subgroup analysis, it is called post hoc analysis, which should always be avoided. Because if you don't get the result that you want, then you try and find a subgroup where you get the result that you want and highlight that and say, in this group, this is what has happened. And keep on talking about that. This is called post hoc analysis, which should not be done. And it is frowned upon in statistics purpose. So the subgroup analysis has to have been done usually in prospective study. If you have already, in your protocol said, we are going to study 10,000 people in each group, but then we will study these, group in, these patients in different subgroups also. And then you do subgroup analysis, maybe diabetic, non-diabetic, smokers, non-smokers, obesity, non-obesity. Then you are well within your rights to do the subgroup analysis. But if you have not done so, then you add it as a as an afterthought later, because your results were not what you were expecting. Then what happens is, then there is a huge credibility gap, and then there is your results may not be looked at with with integrity. So that is why.
And yes,
Yeah.
sir.
Yeah.
Yes, sir. Yes, sir. No, that's what I thought you finished. Yeah.
Did you understand?
Tell us, sir.
Nikita?
Yes, sir. Yes, sir. I did understand, sir.
Your points were correct.
Limitation. Yes.
You have to understand that if you do the subgroup analysis, it will amount to post hoc analysis, which is not correct.
Agree,
And
sir.
also, Nikita and Vinod, what you people have to understand is there are very specific points which they are trying to address. What those points are, whether cholecystectomy worsened the adverse outcomes of pregnancy or no. Whether and one more question is whether intervention and no intervention, whether there was any difference. So here they're not trying to find out the comorbidities and whether that affecting cholecystectomy, whether that affecting anything else with respect to gallbladder, that they're not trying to study. So doing a subgroup analysis will not alter the questions what they were asking, results of those questions.
Agree, sir. But as they have mentioned in the methodology, I was expecting or assuming that's it, sir.
Yeah,
But
we
it's
didn't.
not the
We're
end
not questioning
objective.
your.
Yes.
You are not questioning your this thing. All your whatever questions you raised were absolutely correct. But what you try to understand is it's a retrospective study, as Ravi Shankar sir said, and trying to do those subgroup analysis will lead to a bias where you want to prove something and you will try to point your study towards that. So and you won't have all the data in a retrospective study. Whatever the follow up they're telling for 1 year, would have been the whatever has been mentioned in those documents for the insurance. You won't have the accurate follow-up of whether comorbidities, how bad was it, what was the treatment being given, and all those things will not be there. So the data will not be accurate. So whatever they're trying to say is for 1 year follow-up, whatever is the records are available, they've said. But it is not going to alter whatever the questions they've asked. For those, what will be the outcome? That will not differ based on these data.
Yes, sir. Yes, sir.
Okay, Praveen?
Yes, sir.
Repeat.
Sir, my doubt was it would be better if they had also included the child health.
Correct. I think, yeah, that is. See, I think, basically, because the organogenesis is a multifactorial thing. Mainly, I think, dictated by the genetic factors, because I think, as you know, there are some, and then autosomal regressive, autosomal dominant, all these things, family and genetic. I think they are the ones which dictate or particular exposure to some chemical or smoking or whatever it is. Because it is a multifactorial thing, just ascribing the organogenesis or problems associated with to the child to surgery or cholecystectomy will be difficult.
Yes, sir.
So that, and you will probably need huge numbers to, for example, you need 1 lakh patients in each group or something like that to actually, detect a detectable difference between, let us say, patient who underwent cholecystectomy and the patient who didn't undergo cholecystectomy. In common problems, you need a huge group, huge numbers on either side to show detectable difference. On the other hand, if you are studying rarer conditions, you don't need so many patients because the difference will be obvious. You understand? So,
Yes, sir. Yes.
So let us say, 100 kids develop some organogenesis problems and, whatever in the surgery group and another 150 in the non-surgery group. How will you say that, it's very difficult to say because there's so many other factors which you cannot actually, compare.
Yes, sir.
Why they didn't, look at the child, but it would have been nice if they had given the data first.
Yes, sir.
And
Yes.
also probably because if there was anything, it would have been added onto that insurance data. Because that child, if suppose something would have happened, the documentation would have probably would be there, and they would have told us if there was anything. Probably there was nothing there.
Okay, sir.
Abdul, anything to add?
No, sir, nothing to add. Hello.
Praveen.
Continue, Praveen.
Yes, sir. Coming to discussion, this was the first population-based study examining the risk of adverse pregnancy outcomes associated with both acute cholecystitis and its treatment options. And it is novel as it is being up to date, and it is the first paper to use large cohort size to account for trimester-specific risk in both comparisons. As said previously, acute cholecystitis is associated with higher risk of adverse pregnancy outcomes compared with no diagnosis of acute cholecystitis among patients with acute cholecystitis. The risk of adverse pregnancy outcomes was lower in those who received surgery than among those who did not. And these results support that professional guidelines recommending cholecystectomy across all trimesters. But only around 34.5% of pregnant patients with acute cholecystitis is undergoing surgery during pregnancy, suggesting that there is only limited adherence to the guidelines. A study by Coe and colleagues reported that there is a higher cost and longer hospital length of stay with cholecystectomy in pregnant patients compared with cholecystectomy in non-pregnant patients. And a study by Fong and colleagues showed that cholecystectomy in third trimester was associated with worse maternal and procedure-related outcomes compared with cholecystectomy after delivery. But neither study compared the risk of surgical treatment with risk of non-operative management during pregnancy and did not account for different trimesters of pregnancy. In another study by Cheng and colleagues, they studied the cholecystectomy outcomes during different trimester of pregnancy, and they showed that cholecystectomy in the third trimester was associated with higher maternal and fetal complications and greater economic burden when compared to cholecystectomy in first and second trimesters. But in this comparison, they include cholecystectomy for a wide range of biliary diseases with variable clinical severity, such as choledocholysis, gallstone pancreatitis, without any follow-up.
No, what is the more major problem?
Sir?
What is the more major problem in all of these studies? Strong studies, go back to the previous two studies you mentioned. Kai and Fong.
Colleagues and Fong, sir. Yes, sir.
So what is the major problem?
Sir, in Fong study, they suggested that in third trimester has worse outcomes, sir, in both Fong and the Cheng study.
But what is the problem with their conclusion?
Sir, in conclusion, they did not compare the non-operative with the operative, sir. They just took only the operative and they have finalized, they come to that conclusion.
Exactly. See, if you just say 80 patients in this group underwent surgery and in them these are the complications. What about the other, if you are comparing 80 patients who did not undergo surgery, medical management, what happened to them? What were the complications in them? See, whenever we consent the patient, informed consent, apart from enlisting all the complications associated with anesthesia and surgery, you also have to enlist the complications if you don't undergo surgery. What can happen? For example, with gallbladder itself, if patient comes to you with gallstone disease, you have to tell them acute cholecystitis, empyema gallbladder, perforation of the gallbladder, acute gallstone pancreatitis, and acute cholangitis. And in long-term patients, possible risk of malignancy. If you don't tell all of these things, then it won't become an informed consent. So when informed consent itself includes this, how can studies be considered credible if they have not compared the operative and non-operative treatment?
Yes, sir.
Yeah, carry on.
Coming to conclusion from this study, it suggests that cholecystectomy for patients presenting with acute cholecystitis across trimesters was associated with lower risk of adverse pregnancy outcomes compared with non-operative management. And when examined by trimester wise, this association was found first and third trimester. And while cholecystectomy is recommended by professional society guidelines, cholecystectomy is infrequently performed during the pregnancy, especially in third trimester, when it may offer the greatest risk reduction.
Okay, I know. Is it
Yes.
clinically relevant?
Yes, so like as it is said that like cholecystectomy is having like it is helping in improving the status of adverse pregnancy outcomes, especially in the third trimester where the patient can be offered that, then like consider taking into account organogenesis and everything is completed, so it can be considered relevant. And like they have included, the study includes a large sample size with all the trimesters, so it can be clinically relevant, sir.
Yes, you have answered well. But in the exam, I asked you, is it clinically
Stick to
relevant?
point. Only whatever sir asked you have to answer.
Yes, sir, it is clinical. It is
No.
clinically. Okay.
If I can ask you why, then you have to go about all these things. So that is why I asked you the big question you fell for it. Okay, Nikita, would you change your practice based on this study?
Based on the conclusion, yes, sir. But based on the study, I would still be apprehensive, sir.
Why?
Why?
Because it's a retrospective study. One of the major cons, and it may not set to our current scenario. It's a complete American.
No, it does actually, because what is relevant 15 years ago is more relevant today because everything about anesthesia, surgical technique, anesthetic technique, safety of anesthetic drugs, awareness of what are the problems associated with it, all these things have improved enormously. It is more relevant today than it was 20 years ago. Niranjan?
Yes, sir. Absolutely. I agree.
So I think, see, all data that comes through prospective randomized control trial, of course, it is the meta-analysis or systematic review of multiple, randomized, equally comparable randomized control trials is the gold standard, no doubt about that. But you can't dismiss retrospective studies, lightly, because sometimes
There are certain situations where you can't do a randomized prospective study here, where you can't randomize. It will be unethical for you to classify those pregnant patients into operative or non-operative group. Nobody will give a consent for that, or nor the ethical ethics will allow you to do that.
see, just giving an example, I have done about 10 or 15, patients, who have had acute cholecystitis during pregnancy. And when I remember one particular girl, she said, I would rather die or, get rid of my pregnancy. I don't want to suffer like this. You can't then tell that woman, I have randomized you to non-operative treatment, so I won't operate on. So, sometimes selection is based on the patient's request also. So as Niranjan said, it will be unethical to randomize patients because ultimately some of the patients may decide, even if they have been randomized for operating treatment, they say, I would rather bear the pain, but I don't want anything to happen to my child. However low the risk is, I would, go through the pain and I will wait till after the pregnancy and get operated. There is nothing wrong with what she is saying. So you can't randomize her and say, I will operate on you. So sometimes good data does come, if they have done all their level best. See, what you have to understand is the data has been collected by non-medical people or people who had no interest in the outcomes. They were only interested in whether they could give insurance or not. So they would not have considered, all these nuances of a research. Their only interest is whether I should give money to this person or not, or refuse the money. So the data has been collected by people who have no interest in the outcomes. And then somebody has gone through a huge cohort of patients and then applied the principle of propensity score matching with inverse, proportions. So that is the best data you can get. Of course, it is not as good as, prospective, but I think it certainly will enlighten. I learned that, I was of the impression that second and trimesters are safe. First trimester, I would still not offer surgery. But with this data, I think even first trimester, I will offer surgery. Niranjan?
Yes, sir, I agree. Only thing is you have to tell them the risks of that, whatever the adverse outcomes of pregnancy, and make them understand if you leave it like that, those adverse outcomes are more, even more, than when compared to surgery.
So the homework for all of you is to find out what are the risks of, this child problems with the child and all that in the first trimester. Is there any good data to support your doubts? Go through literature and put it up in our group. Okay, Nikita, all of
Yes,
you.
sir. Yes.
Yes, sir.
Yes.
Praveen, your collateral reading.
Yes, sir. On the review of literature, a paper with surgical trends in management of acute cholecystitis during pregnancy by Vincent Cheng. In the results, with a total of 23,939 pregnant women, during the study period, 36.3% of them were managed non-operatively, while 59.6% were underwent laparoscopic and 4.1% had undergone open cholecystectomy. And when compared to non-operative management, laparoscopic cholecystectomy for acute cholecystitis was significantly associated with lower rates of preterm delivery, labor, or abortion. And each day that laparoscopic cholecystectomy was delayed, it showed there is a significantly associated with an increased risk of fetal complications. In another study by Vincent Chen, which was showed paper on association between trimester and outcomes after cholecystectomy during pregnancy. Out of 819 pregnant women, 217 were in first trimester, 381 in second, and 221 in third trimester. And when compared to second trimester, cholecystectomy during the first trimester was not associated with higher rates of complication. However, cholecystectomy during third trimester was associated with higher rate of preterm delivery and overall maternal and fetal complications. In another study by Ziweng Feng, with cholecystectomy
No,
during
Praveen,
third
you're
trimester,
not telling us the conclusions. What did they conclude, those papers? You're
same
not
thing
telling
they
us the
have, same the results they have kept in the conclusion, sir.
Okay, continue.
Yes, sir. In another study by Ziweng Feng on cholecystectomy during third trimester of pregnancy, whether to proceed or delay. Here, women undergoing cholecystectomy during third trimester of pregnancy were 403 were compared with women not going the procedure. That is of 17,490 patients. Here in the results, cholecystectomy during pregnancy was more likely to require hospitalization, and it is more likely to be performed when it was for performed in the open surgery. There is more of required hospitalization, and the maternal outcomes were high as well as with a length of hospital stay. They concluded that when maternal delivery and procedure-related outcomes, it was worse when cholecystectomy was performed during third trimester of pregnancy. And preterm delivery, it is associated with multiple adverse infant outcomes, and it was increased in third trimester women. But whenever possible, cholecystectomy should be delayed until the postpartum period.
Praveen, did you look for any
Sir,
guidelines? What does the guideline say? Like
sir,
SAGES,
no, sir, there was no any particular guidelines, sir.
there are guidelines, Praveen.
I, I check it,
What does
sir.
the Cochrane review say? That will be your homework.
Okay, sir.
Sir,
Hello?
yes, sir.
I think you are right. You need to, SAGES guidelines if there are any guidelines from major association, you look. You look at
Japanese this thing guidelines, and also there are guidelines. Cochrane review. What does a Cochrane review say? They would have done the meta-analysis and of all the studies, and they would have given us the guidelines.
So I'll check it, sir.
Yeah, that is a homework for everyone.
Yes, sir.
So,
Okay. Yes, sir.
Nikita, what is your overall impression? First of how Praveen did, and second, what would you do?
Praveen did it well, sir. Choosing the topic itself was a very good topic, sir. So, and the analysis also was nice, sir.
Okay. What about the conclusion that we have drawn? Would you agree with that?
I would agree with the presenting like results, sir.
Hmm. No, but after those three papers that we the collateral reading, what would be your thinking?
In my personal practice or point of view, I would recommend surgery to the patients in all the trimesters.
Hmm.
Yes, sir. It would definitely open the surgical aspect to all the trimesters, but final evidence and guidelines are yet to be reviewed, sir.
Tanya?
So he did well. A good topic for discussion. Like Nikita said, statistics also well explained. And yes, sir, I would think that as Niranjan sir said, explaining the patient about the pros and cons of undergoing surgery and the side effect or the adverse effects that are associated should have, if patient presenting with acute cholecystitis in pregnancy should plan for surgery, sir, given that after explaining the patient everything in all trimesters.
Abdul,
Nice topic to have selected because even I had doubts regarding when to operate, regarding the trimester surgery, and that's all. Well presented.
I think
Sir,
Niranjan, I will give my opinion and then you can do the final.
yes, sir.
See, I think Praveen, you did well. So the topic well in conjunction with Niranjan, and also you explained you seem to have understood the statistics well, which is good. I think that it is very important that you make an effort to understand statistics. One, because it will improve your understanding. Second, it will also give you the knowledge whether the right statistics have been applied. Because if you apply the wrong statistics, you can derive wrong conclusions. So that is the important thing. In terms of the thing, I think what Niranjan said is, I think I'm awaiting the guideline from all the major bodies, because it puts me in dilemma. I think first and second trimester, I think we should offer surgery and we should do the surgery. But if the patient develops symptoms in the third trimester, if the rate of complications and things are that high, we should worry whether we should offer surgery or should we manage it conservatively. So I think maybe depending on how closer to the term the lady is, you can defer the surgery till after the pregnancy, because there are 2-3 papers which indicate higher complication rates in the third trimester. So if the patient has developed symptoms in the first and second, probably the guidelines now suggest that we should offer surgery to them, having explained the risk. But third trimester, I'm not so sure. Niranjan?
Yes, sir. Whatever I had looked up for the data, I will again look it up and forward it in the group. That what currently they're saying, even including SAGE's guidelines, that it is safer to operate early, especially in case of cholecystitis. If it is just a symptomatic cholelithiasis, you may try to push it. But if it is acute cholecystitis, what they say is it is better to operate early rather than delay, because complications of delaying it will probably have adverse events on the pregnancy outcomes. That is what I've seen. Let us review again. Let us go through the things again, and I'll also try to find some guidelines and share it. Apart from that, I agree with all the points. Praveen, well done.
Thank you, sir.
Well done.
So we'll conclude, sir, if no other comments or questions.
Well done, Praveen.
Thank you, sir.
Thank you. Thank you, sir.
Okay, thank you, Niranjan.